Now continuing with the lab diagnosis of COVID-19, specimens that are to be used are throat and nasal swabs. NAT can be done, nucleic acid amplification testing. Formats are real-time PCR, RT-PCR, automated formats like CVNAT and TrueNAT. Gene target screening, E, N, and M genes, and confirmatory are RD, RP, and N2 genes. Antigen detection assay, point of care test detects the nucleocapsid protein antigen in nasopharyngeal swab. Antibody IgG detection assay used for serosurveillance and surveying high risk and vulnerable group, not for clinical diagnosis. Sequencing to determine the mutation in the viral genome, and viral culture used for research purpose, and non-specific tests include radiology, chest CT scan, ground glass appearance, and biomarkers like interleukin 6 and D dimers can also be done. Lab diagnosis is necessary only in specific indications as per the Government of India, such as patients with influenza-like illness (ILI) and symptoms or severe acute respiratory infection (SARI). Asymptomatic detect and high-risk contacts of a confirmed case to be tested once between day 5 and day 10 of the contact. History of international travel in the last 14 days. Specimen collection and transport. Preferred specimen throat, that is oropharyngeal and nasal swabs are the preferred specimen. Dacron or polyester flock swabs are used dipped in viral transport media (VTM) after collection. Alternative specimens include nasopharyngeal swab, bronchoalveolar lavage, or endotracheal aspirate in ventilated patients. Appropriate PPE should be used for specimen collections such as gloves, gown, N95 respirator, and face shield. Specimen transport and packing. Samples collected should be properly labeled, packed in 3 layers triple packaging method, and transported to the laboratory maintaining an adequate cold chain. Storage upon receipt. The specimen should be stored in appropriate temperature 4 degrees Celsius for less than 5 days and 77 degrees Celsius minus 77 degrees Celsius for more than 5 days. Biosafety precaution. Initial processing of the specimen before inactivation should take place in a biological safety cabinet. Laboratory should have the following safety facility. For NAT require biosafety level 2 facility. For culture require biosafety level 3 facility. And for point of care test, antigen detection can be performed without employing a BSc. Nucleic acid amplification testing NAT. Real-time PCR, real-time reverse transcriptase PCR is the gold standard test for diagnosis of COVID-19. The average time taken is around 4 to 5 hours from the receipt of the sample to generation of the result. The advantage of this platform lies in its accuracy of detection as well as the ability to run up to 90 samples in a single run. Therefore, if available, this platform should be used as a frontline test for the diagnosis of SARS-CoV-2. Gene targets. Most of the commercial kits target 2 genes performed in single reaction, one for screening and other for confirmatory. Gene targets for screening are genus specific, that is specific for SARS-CoV-2, beta coronavirus. Spike protein S, envelope protein E, membrane protein M, nucleocapsid protein N. Gene targets for confirmation are species specific, that is specific for SARS-CoV-2, RNA dependent RNA polymerase RDRP, open reading frames ORF1A or B, and N2 nucleic acid. Principal most commercial kits available are based on qualitative real-time PCR. The target genes in the specimen is amplified in the thermocycler. In this figure, we can see the interpretation of the real-time PCR result of COVID-19 diagnosis. Positive shows RNP, E gene and RDRP gene, while negative shows only RNP gene. When the amplicon binds with the probe, a fluorescence is generated. The point at which the fluorescence starts in the cycle threshold CT of the run. A sample is considered positive when both screening as well as confirmatory genes are detected within a CT value less than or equal to 40 cycles. Detectable NAT becomes positive as early as day 1 of onset of symptom, usually after 5 days of infection, and starts to decline by 3rd week and subsequently becomes undetectable. Automated real-time PCR. Several automated real-time PCR are commercially available such as TrueNAT and CVNAT, cartridge-based nucleic acid amplification test, example GeneXpert. Both these systems are already in use for the diagnosis of tuberculosis. Advantages of these systems include these platforms have widespread availability even at district and primary health center, as well as the systems are already in use for diagnosis of tuberculosis and other infectious diseases. They have a quick turnaround time of 30 to 60 minutes as well. Now, this is the course of the diagnostic markers in COVID-19. Initially, SARS-CoV-2 RNA increases after 7 days and peak becomes available at 14 days and then begins to decline. IgM becomes detectable from 17 days, 7 days, peak comes at 14 days and declines after 21 days. And IgG production begins at 14 days and remains in blood and provides long-term immunity. Now coming on, now the fully automated technique is RT-PCR, involves minimal handling, therefore possesses minimum biosafety hazard. Safety is further augmented by the closed nature of the platforms. The targets used are CBNAT2 targets are used, E gene for screening and N2 gene for confirmation, and TrueNAT2 targets are used, E gene for screening and RDRP gene for confirmation. However, disadvantages of the systems include only 1 to 4 samples can be tested in one run, therefore suitable only for laboratories with less sample load, 24 to 48 samples a day. And antigen detection. A rapid chromatographic immunoassay is commercially available SD biosensor for qualitative detection of specific antigens, nucleic acid protein to SARS-CoV-2. Nasopharyngeal swab after collection should be immersed and squeezed in the viral extraction buffer provided with the kit. This buffer inactivates the virus, releasing the antigen. As a point of care test conducted at the bedside within 1 hour, as the antigen in the extracted buffer is stable only for an hour. Performance: it is highly specific 99 to 100% with moderate sensitivity 50 to 84%. Therefore, symptomatic but negative patients should be essentially referred as real time PCR test. There are various other antigen detection kits under validation which may be marketed in near future. Antibody detection. IgG antibodies generally start appearing after 2 weeks of the onset of infection once the individual has recovered and last for several months. Therefore, the IgG test should not be used for clinical diagnosis. ELISA, chemiluminescence, and immunochromatographic test formats are available for the detection of IgG antibodies. They may be useful in the following situation: serosurveillance purpose to estimate the proportion of population exposed to infection with SARS-CoV-2, including asymptomatic individuals, so that appropriate public health interventions can be planned and implemented for prevention and control of the disease. Survey in high risk or vulnerable populations such as healthcare workers, frontline workers, immunocompromised individuals, individuals in containment zones, police and security personnel, etc., to know who has been infected within the past and has now recovered. Sequencing method played a role in initial identification of SARS-CoV-2 as well. It's not used routinely for diagnostic purpose. However, next generation sequencing and metagnomic next generation sequencing will be needed for determining the mutations in the genome of SARS-CoV-2. Viral culture, although not recommended for diagnostic purpose, viral culture can be used for research purposes, uh, such as understanding the properties of virus and development of vaccine. Non-specific test, prognostic marker. There are several prognostic markers which can be used in setting of ARDS. Elevated interleukin 6 levels indicates cytokine storm. Elevated D dimer indicates the presence of high level of fibrin degeneration products, thus suggesting an underlying coagulopathy. Elevated serum ferritin indicates inflammation, and severe lymphopenia. Elevated C-reactive protein marker of acute inflammation. CT scan of lung shows ground glass appearance and or consolidation. Now, the treatment: currently there is no definitive therapy for COVID-19. However, many clinical trials are going on. They can be managed. Symptomatic management: the mainstay of treatment is a early supportive therapy for symptomatic management in patients with severe respiratory distress. Supplemental oxygen therapy is given immediately. High flow nasal cannula oxygenation, non-invasive mechanical ventilation. Mechanical ventilation in patients with moderate or severe ARDS, high PEEP positive and expiratory pressure instead of low PEEP suggested. And management of septic shock by vasopressors, fluid replacement by crystalloids such as normal saline and Ringer's lactate. Now, the patients could be managed by two ways: home isolation indicated for the asymptomatic or mild cases, and hospitalization indicated for moderate to severe cases with risk factors like diabetes, immunosuppression, etc. Okay, the symptomatic management we have discussed, it includes supplemental oxygen to maintain SpO2 and mechanical ventilation. Others can be steroid anticoagulant like heparin to prevent coagulopathy and management of shock. Now, the investigation therapy: few drugs are now recommended like remdesivir. It interferes with the action of viral RNA-dependent RNA polymerase. Indication: it may be considered in patients with moderate disease, those on oxygen. 200 mg IV on day 1 followed by 100 mg IV daily for 5 days, and contraindicated in children, pregnancy, lactation, liver or renal impairment. Other therapy can be convalescent plasma therapy. The plasma of patients recovered from COVID-19 contains neutralizing antibodies against SARS-CoV-2 virus. These antibodies are believed to eliminate the virus completely. Indication may be considered in patients with moderate disease who are not improving. Oxygen requirement is progressively increasing despite the use of steroids. Dose is variable, ranging from 4 to 13 ml per kg, usually 200 ml. Single dose given slowly over not less than 2 hours. Other drug can be tocilizumab, is a monoclonal antibody against interleukin 6 receptor, the most important cytokine raised in the cytokine storm. Indication: it may be considered in patients with moderate disease with progressively increasing oxygen requirements and in mechanically ventilated patients not improving despite the use of steroids. 8 mg per kg, maximum 800 mg at one time, given slowly in 100 ml normal saline over 1 hour. Special consideration: it is given only when there is raised inflammatory markers, example CRP, ferritin, interleukin 6. Should be monitored for secondary bacterial infection and neutropenia. Active infections and tuberculosis should be ruled out before use. Hydrochloroquine (HCQ) could be used. It may be effective in early course of disease and should be avoided in patients with severe disease. And discharge policy: as per the current guideline of Government of India, the patient can be discharged and isolation can be discontinued after the resolution of clinical symptoms and maintaining stable O2 saturation more than 94% for 72 hours. Okay, so these were all the drugs which could be used, like favipiravir, remdesivir, lopinavir, ritonavir, and hydroxychloroquine. Cytokines like tocilizumab or sarilumab and tofactinib, and convalescent plasma therapy could be used, and other drugs like chemostat, mesylate, and hesperidine were also used. Now, before we discuss the prophylaxis, let us discuss some vaccines. Several vaccines are available for COVID-19. Indication: COVID-19 vaccination indicated for all individuals aged more than equal to 15 years. Covaxin is a whole virion inactivated vaccine which uses spike protein as a target. This is mentioned in the new edition of Apurba Sastry. It is administered in 2 doses 4 to 6 weeks apart by IM route. Covishield is based on non-replicating adenovirus vector expressing like spike protein. It is administered in 2 doses 12 to 16 weeks apart by IM route. Sputnik V vaccine is a Russian vaccine also based on the adenovirus vector. It's given in 2 doses by IM route. COVID-19 nasal vaccine: Government of India has approved the use of world's first needleless vaccine called Inovac, developed by Bharat Biotech. It is delivered by nasal route. Precaution dose: the third dose of COVID-19 vaccine is recommended to use in high-risk groups. Interchangeability between the vaccine is not permitted. Storage: Covaxin and Covishield can be stored as 2 to 8 degrees Celsius, whereas Sputnik V needs to be stored as minus 18 degrees Celsius. Other than non-COVID-19 vaccine can be administered only after 14 days gap of COVID vaccination. Efficacy: COVID-19 vaccine induce an adequate immune response, 70 to 90% efficacy in about 2 to 3 weeks after the second dose. The duration of immunity is yet to be determined. Individuals infected with COVID-19 should defer the COVID-19 vaccination till 12 weeks after recovery. And CoWIN, a COVID vaccine intelligence network, is an Indian government web portal for COVID-19 vaccination registration and also for obtaining the certificate after vaccination. Now, the adverse effects: most vaccines are proven to be safe except for mild adverse reactions such as injection site pain, fever, tiredness, myalgia, fatigue, dizziness, and headache. And the vaccine also prevents some serious illness like COVID-19. Vaccine provides strong protection against the serious illness, hospitalization, and death. However, vaccinated individuals are still at risk of acquiring infection, although the risk is lower than that in non-vaccinated people. Therefore, vaccinated individuals should continue to follow all the infection control measures as before. Okay, so this was about the vaccines. Now coming on to the infection prevention and control. Infection prevention and control is the most effective method currently available for the prevention of COVID-19. Following are the key IPC measures need to be strictly followed. IPC measures of droplet and contact precaution need to be followed by healthcare workers while handling COVID-19 cases, except for aerosol generating products where airborne precaution need to be followed. Hand hygiene: as contact mode appears to be an important mode of transmission, absolute hand hygiene is probably the most effective method for prevention of COVID-19. Hand hygiene needs to be performed whenever opportunity arises and must be performed by the correct technique for appropriate duration, 20-40 seconds for hand rub. Personal protective equipment: HCWs giving care to COVID-19 suspects should wear personal protective equipment, should wear a medical 3-ply mask, a pair of gloves, gown, and face shield. Medical mask should be replaced by N95 respirator if AGPs are carried out. HCW working in non-COVID areas should wear a medical 3-ply mask. This is referred to as targeted continuous medical mask. Should wear masks during all routine activities throughout the entire shift. Masks are only changed if they become soiled, wet, or damaged, or at the end of shift. Front part of the mask should never be touched. Mask should never be hanged around the neck. Anyone entering the healthcare facility must wear the face mask, cloth, fabric mask, regardless of the activities involved in. This is referred to as universal masking in healthcare facilities. So in the PPE kit, there is face shield or goggles, medical 3-ply mask changed with N95 respirator if there is aerosol risk, and one pair of gloves with gown, and boots are also recommended. Now the environmental cleaning. SARS-CoV-2 may survive on surface and floor for a variable period ranging from few hours to as long as 9 days. This may be a potential source of transmission by indirect contact. Therefore, the following measures need to be followed. Floor and surfaces should be cleaned with a detergent followed by disinfected with sodium hypochlorite 0.5%. Cleaning of equipment or patient care items such as stethoscope, beeper, apparatus, etc. should be done by using 70% alcohol. High-touch surfaces such as lift button, rail of the staircase, patient trolley, bed rails, bed frames, bedside table, door handle should be frequently disinfected with alcohol. And terminal disinfection in patient care room after discharge or transfer of patients must be followed. Other IPC measures, respiratory hygiene and cough etiquette such as wearing medical masks by all individuals who are symptomatic, hand wash immediately after sneezing or coughing. Biomedical waste management should be carried out as per the 2016 guideline. However, additional precautions are taken such as use of double bag, use of dedicated trolley and collection bins labeled as COVID-19 waste, and disinfecting outer bag with hypochlorite before handing over. Laundry. All linens used for COVID-19 patients should be washed at 60 to 90 degrees Celsius with laundry detergent, followed by soaking in 0.1% sodium hypochlorite for approximately 30 minutes and then dried. Now the IPC measure for general public: hand wash, frequent hand wash necessary for after contact with other individuals, high touch area, public spaces, after receipt of any item, after blowing nose, coughing, sneezing, touching of eyes, nose and mouth with unwashed hand must be avoided. Social distancing. Ideally, people should stay at home as much as possible. If not possible, 1 meter, like 2 arm distance, should be strictly maintained from other people at all times, no matter how close is the person, how important is the work involved. As droplet can travel a maximum of 1 meter distance, therefore the social distance of 1 meter would prevent the droplet transmission. Environmental cleaning. Frequently touched surfaces should be disinfected daily. This includes tables, doorknobs, light switches, countertops, handles, desks, phones, keyboards, toilet, faucets, and sinks. If the surfaces are dirty, then should be cleaned with detergents of soap and water prior to disinfection. Cloth mask or non-medicated mask. Everyone should wear a cloth face mask when they have to go out in public. For grocery store, for example, it primarily aims at source control, that is preventing transmission from the wearers to others. Cloth masks are made of a variety of fabrics such as polypropylene, should comprise of at least 2 layers. Internal layers are made up of water-absorbing hydrophilic fabrics to readily absorb droplets, and external is a synthetic material hydrophobic, which does not easily absorb liquid. They should not be used in a hospital setting as there is no filter used. They can be washed and reused, should not be shared between individuals. Now the measures taken by the government were quarantine. Quarantine refers to restriction of the movement of healthy people who are exposed to a confirmed case. Actually, this is PSM part, but okay, we are covering in this. It aims to prevent the transmission if they develop a disease subsequently. Duration. Quarantine period is usually kept as maximum incubation period, that is 14 days in case of COVID-19. Quarantine center. There are two types of centers: facility quarantine and home quarantine. Provided by the government are the facility center. Various centers are converted into quarantine facilities like schools, marriage halls, mandaps, hotels, etc. High risk contacts are usually kept in facility center. Low risk contacts are usually sent for home quarantine. Indication for quarantine. WHO has recommended the following: exposure occurring from -2 to +14 days of onset of symptoms in COVID-19 patient should be considered as contacts, and exposed persons should be sent for quarantine. Face-to-face contact with COVID-19 patient within 1 meter for more than 15 minutes. PPE breach. Providing direct care for COVID-19 patients without using PPE or inappropriate use of PPE mounting to breach. or staying in same close environment as COVID-19 patients, including sharing a workplace, classroom or household, cinema hall, or being at the same gathering for any amount of time. Traveling in close proximity with COVID-19 patient in any kind of conveyance and other situations as indicated by local risk assessment. Lockdown. Lockdown refers to the limiting of the movement of the entire population as a preventive measure against COVID-19 pandemic. It was adopted by several countries worldwide, including India. The India adopted nationwide lockdown in four phases from 25th March to 31st May. Subsequently, the state-specific lockdown was followed in hotspot areas. Shut down all services, including offices, shop, private and government organizations, were shut down, except for emergency services such as food and health. Objective of lockdown: based on exposure risk, entire population can be divided into four groups. Lockdown has a definitive objective of for each of these groups. Now, comparison between and the objectives of lockdown during COVID-19 pandemic. Group A: COVID-19 positive cases are admitted in the COVID care facility. Group B: the pass-by contacts include anyone who is exposed to the case but beyond the memory recall. And the most vulnerable group, nobody including themselves knows who is category B. It is impossible to trace category B except for performing passive surveillance of whole community, which is practically very difficult. Lockdown aims at immobilizing category B. If anyone develops symptoms, they'll be referred to hospital. Others who do not develop symptoms are either unexposed individuals or asymptomatic contact. They get recovered during the lockdown period and therefore will no longer transmit the infection. C are the close contact of COVID-19 positive cases like family members and office staff. They are traced easily by active surveillance as they are immobilized at home. Rest of the community who are not exposed at COVID-19 positive case, the most important objective of lockdown is immobilizing category D, so that they will no longer come in contact with others, especially category B. Now, lastly, is the cluster containment strategy. The government has adopted cluster containment strategy in areas where cases are reported either in singly or in clusters, local transmission. The objective is to contain the disease within a defined geographic area by early detection of cases, breaking the chain of the transmission and thus preventing the spread to new cases causing community transmission. Components of the case strategy include geographic quarantine, social distancing measures, enhanced active surveillance, testing all suspected cases, isolation of cases, quarantine of contacts, risk of communication to create awareness among public on preventive public health measures. Containment zone: it is determined by four factors: index case or cluster called as epicenter, the listing and mapping of contacts, geographical distribution of cases and contacts around the epicenter, and administrative boundaries within urban cities or towns or rural areas. A buffer zone of additional 5 km radius will be identified also. The knowledge about COVID-19 is evolving and intense researches are ongoing on various areas of disease. Therefore, now all the WHO and Government of India information can be updated as well. Now, an assay on a 65-year-old patient without wearing any mask, complaints of dry cough, sore throat, fever, visited hospital. Security guided him to go to the casualty. Resident doctor without a mask took the history and examined the patient. His throat swab came COVID-19 positive. So we can identify the infection control breaches, lab diagnosis of the disease and infection control measures to prevent the transmission. All this we can write. Pathogenesis and epidemiology of COVID-19 we can write. MCQs. Now, while examining a stable patient COVID-19, all the following PPE are required except gown, gloves, and goggles are required. N95 is required in aerosol cases. Okay. Gene targets for confirmation of COVID-19 include the RNA-dependent RNA polymerase (RDNP), and which of the following is not used for clinical diagnosis of COVID-19 disease. So, antibody detection is not used. Real-time OPCR, TrueNAT, and antigen detection are all used. So this completes our chapter on COVID-19 infections. Okay, next we'll be starting with the miscellaneous viral infection of the respiratory tract. So meanwhile, like, share, subscribe. Thanks for watching.